Welcome to another episode of the MEGIN Spotlight series. Today we are delighted to have Dr. Michael Funke from McGovern Medical School at UTHealth Science Center in Houston as our guest. Hello, Michael.
Hello, Gabriela. Pleasure to be here.
Thank you. UTHealth Neurosciences doctors use MEG scans to help pinpoint the source of epileptic seizures and determine whether a patient is a candidate for surgery. The centre also offers patients access to specialised neurological care at clinics across the Greater Houston area. Let's find out a bit more about your role and how MEG is utilised. So how and why do you, as the medical director of the MEG Centre, utilise MEG technology in epilepsy patients' care plans?
Well, that's an interesting question, and let me make some remarks. The MEG is just one modality in the pre-surgical evaluation of patients with epilepsy. So what we do is part of a major team effort together with my colleagues from the pediatric as well as adult epilepsy programs. We are using many modalities to establish a hypothesis where seizure starts, and hopefully those patients turn out to be candidates for surgery. So it's a big team effort. And the MEG has a specific role as a localization technology. So we can pinpoint on the MRI where the epileptic form activity is coming from, sometimes even where the seizures may start, if you can record one during the evaluation. And those targets are helpful for invasive evaluations like SEEG, but also they present potential targets for surgical resection and other therapy forms where resections might not be as useful or helpful, like the use of neuromodulation devices like RNS.
Okay, thank you. ACMEGS is an expanding professional organisation with the highest level of competence and practice of clinical MEG and clinical credibility contributed collectively by its 21 member centres. You and some of your esteemed MEG colleagues from ACMEGS developed the 10 common evidence-supported indications for MEG in epilepsy surgery. Why was this an important paper for you to collaborate on, and what initiated this work?
Before I come to the specific goal of this paper that we published, let me give you a very short picture what the situation in epilepsy is for our patients. So we have in the United States about 1 million patients, maybe more, that are diagnosed with epilepsy. 2/3 of them respond very well to anti-epileptic medication, and their seizures are well controlled. On the other hand, there's 1/3 of the patients where none of the existing seizure medications can control the seizures. They suffer from continued seizures, and this is the population where MEG also plays a role in. So we know from those patients that cannot be treated with anti-epileptic medication, at least not successfully treated, because seizure freedom in most cases is our goal, about 10 to 50%, 10 is the more conservative estimate, are good candidates for epilepsy surgery. And the other issue is that those patients that are good surgical candidates takes them a long time from diagnosis until they are referred for surgery. So there are some publications stating this. One of them is from Hanef from 2010 in neurology, and they found in their own community that it takes 12 to 17 years from the diagnosis with epilepsy to epilepsy surgery. So that's very long. So MEG can be helpful in identifying good candidates for surgery. There are certain situations where MEG is really helpful and adds additional or unique information. The number of epilepsy surgeries in the United States for many years is around 3,000, maybe a little bit less. And this explains in part why it takes so long for our patients to get there. But as I said, there are indications for MEG that are really helpful. And we, from many discussions with our colleagues, we know there is an a gap of information, and our paper aimed at neurologists in the community as well as epileptologists that don't work with MEG yet, to give them an impression what are good situations to consider sending your patient to an MEG.
It is always very interesting for our audience to hear about specific cases. So, Michael, can you tell us about a case where prior to using MEG, a patient was not considered a candidate for epilepsy surgery, but the utilization of MEG allowed for this and changed the outcome for the patient?
There's one patient that comes to my mind who suffered from intractable seizures, no response to medication. And for about 10, 15 years or so, it was not really believed that he really has seizures because the EEG seemed to be within normal limits, the MRI seemed to be within normal limits. And then at some point, his, at this time, current epileptologist referred him to MEG. We found epileptiform activity, and on a more close-up review of the MRI, exactly in this area, was a structural abnormality. Subsequently, that was surgically removed, and the patient became seizure-free for many years now. So that's a good example how MEG sometimes turns around the situation, and a patient that is considered having a normal MRI suddenly has a structural abnormality and becomes a very good candidate for epilepsy surgery.
Oh, that's nice to hear from a patient. So talking about patients, can you tell us about the benefit of using MEG in pre-surgical evaluation in pediatric cases? So in your experience, how do pediatric patients tolerate, for example, the MEG scans?
So since I'm in the field of clinical MEG, I have to say in the centers I was working and currently working, the majority of the patients referred for MEG are children of all ages, from shortly after birth, like the youngest one we had we had several of those, are 3 months, up to 18, 19, and then they become patients of our adult colleagues. So MEG works for children as well as for adults, and there is no reason to believe children cannot tolerate this. MEG is much, much easier to tolerate than an MRI because it's quiet. There are no sounds. You're in a room with dimmed lights. It's very quiet. You don't hear anything. And hopefully our patients fall asleep, and then we start recording data. So, and all the 10 indications in that paper you mentioned that we published in 2020, this also applies to children, the exact same situations. And yes.
That's good. That's good. So having been in this field for a long time, what advice would you give referring physicians about how to learn about MEG? At the same time, we should also mention the MEG fellowship you offer, which is a fantastic way for a young physician to learn from experts such as yourself.
Thank you for saying this. I couldn't agree more with you, Gabriela. So the field of clinical MEG is relatively young compared to many other methods we use for the evaluation of patients with epilepsy. So clinical MEG started maybe in the early 2000s, so we are 20 years old. And there are opportunities for interested physicians, especially who are interested in surgical epilepsy, to get a fellowship training for MEG. There are 3 institutions right now in the United States who offer such training. One of them is Cleveland Clinics. The other one is Cincinnati Children's, and the third institution is UTHealth. So, and it's like any other clinical fellowship in subspecialties. And we in our institution prefer candidates that have already completed 1-year epilepsy fellowship, because these are the best candidates to learn MEG and expand their skill sets in pre-surgical evaluation of patients with epilepsy. And like, as I mentioned at the very beginning, The newer methods that we are using for evaluation, stereo EEG and MEG, are really going well together. They are like the modern workhorses of pre-surgical evaluation of patients with epilepsy.
Oh, that's really interesting. It sounds like everyone should be doing an MEG fellowship, to be quite honest. Anyway, we've come to the end of our discussions today. So thank you, Michael, for your time today. It's been really informative for our audience, and it's always an honor for us to be able to share insights into MEG utilization in such advanced institutions such as yours, and to communicate this with the wider MEG audience globally. So thanks very much again, and thanks for your support today.
Thank you for the opportunity. Really appreciate it.